Committee will come to order. I'd like to begin this hearing by stating the Oversight mission statement. We exist to secure two fundamental principles. First, that Americans have the right to know that the money Washington takes from them is well spent. And second, Americans deserve an efficient, effective government that works for them. Our duty in the Oversight and Government Reform Committee is to protect these rights. Our solemn responsibility is to hold government accountable to taxpayers, because taxpayers have a right to know what they get from their government. We will work tirelessly in partnership with citizen watchdogs to deliver the facts to the American people, to bring genuine reform to the Federal bureaucracy. This is the mission of Oversight and Government Reform. Today's hearing will explore the problems that result from the lack of transparency, consumer-driven market forces in our health care system. Today's hearing features the testimony of two of the witnesses that are here, Ms. Quincy, that's also coming as well, who last year wrote important, thought-provoking books about the U.S. healthcare system. Both paint a picture where doctors, nurses, and patients are trapped in a system filled with perverse incentives. When providers and patients act upon these incentives, abundant waste and abuse result. According to a report last year from the Institute of Medicine, 30% of U.S. healthcare spending, an amount that exceeds $750 billion, was wasted in 2009. Over the past decade, the growth in healthcare costs almost entirely eliminated income growth for average families. Additionally, medical errors and hospital-acquired infections are a major problem. According to Dr. McCary's testimony, if medical mistakes and preventable infections together were a disease, it would rank as the number 3 most common cause of death in the U.S. after heart disease and cancer. Today's hearing will take a close look at the perverse incentives that lead to rampant waste and inappropriate and harmful medical treatment in the United States healthcare system. Nearly 90% of payment of healthcare services comes directly from third parties. Third-party payment separates the payer of the care from the patient and provides a strong incentive for a doctor to serve the payer of the care rather than serve the patient. The system's also produced a massive bureaucracy focused on claims processing and the creation and management of cumbersome rules. This bureaucracy adds to the expense of healthcare services and creates frustration among healthcare practitioners and patients. A 2009 study in the Archives of Internal Medicine found that 31% of doctors are burned out and 51% of doctors wouldn't recommend the profession to one of their children. I look forward to hearing Dr. Goodman's testimony and the implications of the failure of the healthcare providers to compete on price. I also look forward to hearing about segments of the healthcare system where there is competition and transparency and how we can move public policy more in that direction. Dr. McCary has done service to the country by speaking up about problems within his profession. Unaccountable his book also deals with perverse incentives at the core of the healthcare system, but it's focused on how these incentives lead to substandard care for far too many U.S. hospitals. Here's some examples from his book, and I hope I'm not stealing your thunder on this. In about half of the hospitals in the U.S., fewer than half of the employees at that hospital would feel comfortable having their own care performed in the unit with they work. 25% of all hospital patients experience a preventable medical error. Hospitals make roughly $30,000 more from patients who suffer at least one complication than they do from patients whose procedures go smoothly. Dr. McCary argues that hospitals and doctors fail to compete on quality because the public does not have the information to be able to separate high-quality hospitals from low-quality hospitals for various treatments. I received a letter yesterday from Dr. Keith Smith, which I'd like to enter into the record, a physician at the Surgery Center of Oklahoma City. His hospital is the only place in the nation where all prices are listed online, and competition has driven up quality and driven down price. I ask unanimous consent to enter his letter into the record. Without objection, so moved. Independent experts believe that the Affordable Care Act, despite its name, might very well increase what Americans spend on health care, both in terms of money and in time. Moreover, Obamacare increases Federal government control over U.S. health care system, increases the third-party payment problem, and reduces consumer choice. The health care system needs real reform, and the ideal reform would aim to address the two primary concerns highlighted by today's witnesses: reducing the amount of third-party payment in health care and providing patients with additional information related to health care quality. The health care system has to be reoriented toward value and better outcomes and away from increased utilization and waste. I now recognize the distinguished ranking member, the gentlelady from California, Mrs. Spear, for her opening statement.
Mr. Chairman, thank you, and the witnesses for being here today on a topic that should be front and center, because the cost of health care in this country is one of the huge drivers for personal budgets and for the public budget as well. We spend a great deal of time talking about who should pay health care bills, the consumer, the insurance company, or the government. Another question that should be asked is, why are health care costs so high? Mr. Chairman, I want to submit for the record this Time magazine piece Why Medical Bills Are Killing Us by Stephen Brill, and I'm hopeful that we can invite Mr. Brill to come and speak to us here because he's done an exhaustive study on why the cost of health care is so expensive.
Yeah, without objection.
The majority has suggested that shifting more health care onto consumers, what one of the witnesses will call skin in the game, will lead to lower health care costs in the marketplace. As seen by one of the graphics we're about to put up, consumers already have a great deal of skin in the game. 62% of bankruptcies are related to illness or medical bills. 69% of those who've experienced medical-related bankruptcies were insured at the time of their filing. Healthcare is not a buyer's market, it's a seller's market. It certainly is not a free market. When you have to go to the emergency room, you can't shop around for the best deal like you would for a new TV, cell phone, or car. When the doctor tells you you need an X-ray and a CAT scan, you don't ask how much it will cost. All you want to know is what's wrong and get a diagnosis. The medical economy is clearly a different world than we face in any other parts of our lives. In February, the Time magazine ran the story by Stephen Brill, The Bitter Pill. Brill undertook an exhaustive examination of the medical bills and the actual hospital costs for 8 patients across the United States. The results are shocking and clearly demonstrate how broken our healthcare delivery system is. For example, a patient was charged $283 for a single X-ray that would only cost $20.44 if covered by Medicare. The patient was 64 and unable to buy insurance. If he had been 1 year older, he would have qualified for Medicare. That nonprofit hospital, and I underscore the fact that it's a nonprofit hospital, has a profit margin of 26% and paid its president $1.8 million plus what he earned consulting for pharmaceutical companies last year. A patient at another hospital was charged $199 for a blood test, for which Medicare would have paid $13.94. In yet another case, a patient was billed $7,997 for a stress test using radioactive dye that cost Medicare $554. The bottom line, our system ensures that those least able to pay, those with the most skin in the game, are the ones singled out to pay the highest rates. You have each been provided a copy of the article, and I have already requested unanimous consent. As seen in the next slide, the cost of health care also bears little connection to the quality of the care that is provided. Annual health care spending per person in the United States was higher in 2010 than it was in Australia, Denmark, Japan, Spain, and the United Kingdom. But our life expectancy rate ranked at the bottom. So something is fundamentally wrong. We pay the most and we get the least, and the condition of those is reduced. As Dr. Macari notes in his testimony today, the Institute of Medicine has reported that up to $750 billion, 30% of the total health care spending, may be going to overtreatment, unnecessary tests, and or wasteful spending. In fact, we provide perverse financial incentives to medical providers to provide more services and order more tests. Under a fee-for-service system, the more they order, the more they are paid. Increasingly, they have direct financial stakes in CAT scans, MRI, or pathology services they order. The in-office ancillary service exception and stark prohibition on self-referral has now swallowed the rule. Doctors are encouraged to buy CT and MRI machines and are instructed by the manufacturers on how many scans they need to provide a break-even, and then how many tests they need to order to generate a healthy profit. Last November, the GAO issued a report on advanced imaging showing a direct correlation between self-referral and higher utilization, costing Medicare at least $109 million in 2010, and that's a very conservative figure. The same problem exists in pathology, radiation, physical therapy, and the GAO will have a similar report coming out on those. I will soon be introducing legislation to close this truck-sized loophole and save Medicare billions. Requiring consumers to have more skin in the game would also do little to address the quality of care patients receive. Medical errors and preventable infections are among the leading causes of death in the United States. This has been one of the dirty little secrets in the healthcare industry. The issue of healthcare transparency is not a new one. I actually carried legislation in California in 2000 that requires general acute care hospitals to adopt a formal plan to eliminate or substantially reduce medication-related errors. I introduced this bill because I had learned that medication errors increased the cost of a hospital stay by an average of $4,700. Some in Congress do not like to admit it, but the Affordable Care Act has already got the nation moving in the direction of increased transparency, lower costs, and better outcomes. The Summary of Benefits program created an unprecedented standardized method of communicating health plan information to over 170 million consumers enrolling in private health coverage. The SBC requires providers to give consumers information about health care plans in a uniform layout and in terms they can actually understand. I realize I am 56 seconds over, but let me just finish with this. A new study from the Kaiser Family Foundation demonstrates that the slowdown in costs could cut $500 billion in health care costs over the next decade. Larry Lovett from Kaiser Family Foundation says, quote, "The run-up to the Affordable Care Act and the initiatives put in place by the law are absolutely having an effect, and that providers and payers see health care reforms coming and they want to get ready to lower their costs." So we have much to do, and I thank the Chairman for initiating this hearing so that we can get to the business of making it more affordable for consumers to access health care. I yield back.
Thank you. Members will have 7 days to submit opening statements for the records. We'll now recognize our panel today. Dr. Marty Makary is the Director of Surgical Quality and Safety at Johns Hopkins Hospital and Associate Professor of Health Policy at Johns Hopkins Bloomberg School of Public Health. Dr. John Goodman is the President of the National Center for Policy Analysis. Ms. Lynn Quincy is the Senior Health Policy Analyst at Consumers Union. Pursuant to committee rules, all witnesses are sworn in before they testify, so if you please stand and raise your right hand. Do you solemnly swear or affirm the testimony you are about to give will be the truth, the whole truth, and nothing but the truth, so help you God? Thank you. Let the record reflect that the witnesses answered in the affirmative. You may be seated. In order to allow time for discussion, please limit your testimony to 5 minutes. Your entire written statement will be made part of the record, as all of you have submitted written testimony as well. When we conclude this portion of it, we'll have questions from all the different members that are here, and we'll have some interaction at that time. Dr. Makary, you're our first witness, and we'd be honored to receive your oral testimony now.
Thank you, Mr. Chairman. Thank you, Ranking Member Speer. Thank you, members of the subcommittee, for having me and staff. My name is Marty Makary. I'm a surgeon at Johns Hopkins Hospital, and I'm an associate professor of health policy at the Johns Hopkins Bloomberg School of Public Health. When I recently asked one of my patients, "Why did you come to this hospital?" their answer was, "Because of the parking." That answer embodies what's wrong with American health care. Today, we have 1/5 of the U.S. economy, a marketplace of products with no way for consumers to evaluate those products. While some successful innovations are advancing the science of medicine and the way we deliver care, one problem remains endemic and more costly than ever. It is the wide variation in medical quality in the United States. The Institute of Medicine, as we said, estimates that up to $750 billion, or 30% of everything we do, tests, procedures, studies, may be unnecessary, a form of waste. The cost of the problem is not theoretical or deferred. It's real and immediate. Americans are paying hundreds more for their health insurance this year, and they're getting hit with escalating copays of $100 to $500 per encounter. I have patients complain about copays. American businesses now cite health care costs as the leading reason they have trouble competing with businesses overseas. And when I talk with business leaders, they consistently tell me that they are frustrated paying more and more for health care without any metrics of performance. Every other contractor they have has some way to measure their performance. Now, every proposed solution to this unsustainable financial trajectory calls for measuring hospital performance by tracking patient outcomes. So where are these outcomes? Well, much of it lives in federally funded registries with little or no access to the taxpayers that pay for them. In my field of surgery, the National Pancreas Islet Transplant Registry, funded by the NIH, tracks patient outcomes. When I do an operation and remove a patient's pancreas, we send it to the laboratory, it's then reinfused into the patient's liver. That transplant operation has many variables that are collected and reported to the National Registry. Now, when I try to get access to this registry, even as a researcher with resources, I wasn't able to. Yet this registry is funded by taxpayer dollars. If we had access, we could find out which centers have good outcomes and which centers have bad outcomes. But this data is not available to the public. Similar barriers exist for Medicare and other federally funded registries. After a lot of work, my research team accessed one government-funded database, but under the condition that the hospital names are removed. We looked to see whether hospitals are performing common surgical procedures using the minimally invasive or laparoscopic method in situations where it has been well established to result in lower wound infection rates, less pain for the patient, and better functional outcomes compared to open surgery. Here's what we found. Despite lots of evidence, including an extensive Cochrane review in the medical literature to support lower complication rates of laparoscopy, its use at U.S. hospitals varied widely. In this figure, each dot represents one U.S. hospital, and we graphed the variation. So if you go to a hospital on the left side of the chart, it is highly unlikely that they'll use the laparoscopic approach, even though it's associated with lower infections and better outcomes. And if you go to a hospital on the right side of the graph, 80, 90, 100% chance maybe that you'll get that operation using the better method. This wide variation embodies the problem with a system that's not transparent. The same variation was true of some of the most common procedures in medicine: hysterectomy, colon surgery, and others. Patients make choices in a free market where competition exists, all right, but the competition exists at the wrong level. It exists at the level of valet parking and billboards, leaving patients uninformed about these differences in outcomes. Imagine if you, as a patient, were looking for a hospital to have an appendix removed, one of the most common procedures in America. And you could look up a hospital's outcomes, you could look up the complication rate, and you could look up the percent likelihood that that hospital does laparoscopic surgery. You would likely know where to go. It would likely create competition around patient-centered outcomes, not just volume, and drive the entire marketplace towards good value. Making government-funded databases open to researchers where hospitals can be identified as over- or underperforming centers is one simple step that could be meaningful and allow the free market to work with the competition at the right level. My team has compiled a registry of national registries to look at every database out there looking at patient outcomes. There have been no standards and no coordination of registries. We found that there are over 150 national registries that track patient outcomes. 1/4 are taxpayer funded, yet only 3 make their data available to the public. Making public access a condition of taxpayer funding is one simple reform that would allow the market to cut waste. Transparency also needs to be applied to medical errors, sentinel events like never events, retained sponges. This information is being tracked, but it's not public information. If it were, it would allow the market to work. Finally, transparency can inform patients seeking medical care, create competition, and cut waste in health care. Rewarding hospitals for participation in national registries, public reporting, creating public access to Medicare and ARC databases are important reforms that can realign incentives to focus on what's right.
Dr. McGarry, thank you. Dr. Goodman.
Thank you, Mr. Chairman, members of the committee. Good morning. If something goes wrong with my iPhone, there are a dozen places in Dallas, Texas that I can go to without any appointment and get high-quality, low-cost care. There are places that will send someone to my condo and repair this iPhone in my home. There's a national repair chain that's called iHospital, and the employees are called iDoctors. But if something happens to my body, the average wait in the United States for a patient to see a new doctor is 3 weeks. In Boston, where we're told we have universal coverage, the average wait for a patient to see a new doctor is 2 months. And amazingly, 1 out of every 5 patients that enters a hospital emergency room leaves without ever seeing a doctor because they get tired of waiting. Now, why is the market so kind to my iPhone and so mean to me? I believe the answer is that this iPhone is produced and sold and repaired in a real market with real prices where entrepreneurs know they can make millions of dollars if they solve our problems. Where over in healthcare, we have so completely suppressed the market for year after year, decade after decade, that no one ever sees a real price for anything. No patient, no doctor, no employee, no employer. Basically, we like to think in the United States we're different from other countries. That's a myth both on the left and the right. In the United States, we mainly pay for care the way they pay for it in Canada and Britain. We pay with time and not with money. And in Canada, you visit a doctor, it's free. In the United States, it's almost free. Every time we spend $1 in the doctor's office, only 10 cents is coming out of our own pocket, 90 cents is coming from a third-party payer, an employer, an insurance company, or government. What we have overlooked is that when you suppress the marketplace, when you suppress prices, you elevate the importance of non-price barriers to care. And what are those non-price barriers? Well, how long does it take you on the telephone to get an appointment with a doctor? How many days do you have to wait before you get to see that doctor? How long does it take you to get from your home or office to the doctor's office and back again? And once you're there, how long do you have to wait before you get treated? There's lots and lots of evidence that those non-price barriers to care are a greater deterrent to people getting care than the fee that the doctor charges. And this isn't just true for middle-class patients. It's also true for low-income patients. Now, can the market work in healthcare? My answer is that you show me any part of the healthcare system where the third-party payers aren't. Show me a part of healthcare where there's no Blue Cross, no Medicare, and no employer, and I'll show you a market that's probably working pretty well. In cosmetic surgery, there is no problem with transparency. Patients get a package price covering the doctor, the nurse, the anesthetist, the facility. They know exactly what they're going to pay in advance. There's price competition. Over the last 15 years, the real price of cosmetic surgery has gone down as the real price of every other kind of surgery has gone up. And this is in the face of an incredible increase in demand, all kinds of technological change of the type that we're told increases prices or costs everywhere else. Similarly, in the market for LASIK surgery, you have complete transparency, you have price competition, you have quality competition. Over the last 10 years, the real price of LASIK surgery has come down 25%, even as other kinds of surgery is going up. Again, huge increase in demand, all kinds of technological change. In the international market for medical tourism, you can get a package, transparent price for almost every kind of elective surgery. Hospitals in India and Thailand and Singapore not only compete on price, they post their quality ratings. And the kind of information that Dr. Markey said we can't get on American hospitals, Indian hospitals put up on the internet and they say, here's our infection rate, here's our mortality rate, here's our readmission rate, and by the way, here's what it is at the Cleveland Clinic and the Mayo Clinic. When a hospital does that, you know they're competing on quality. And then what's not very well known is that we have a domestic market for medical tourism because hospitals don't like to tell us that. And so some of the very hospitals that Stephen Brill was writing about might very well go to Canada and tell the patients coming down here for a knee replacement or hip replacement, we'll not only give you a package price, but it's going to be half of what Blue Cross pays. It's going to be lower than what Medicare pays. So this is going on. Hospitals can compete for patients. They are competing for patients. This is not the patients that live near the hospital. It's for foreigners coming to the United States, often to get care that they cannot get in a timely way in their own country. So, Mr. Chairman, I think that that our problems arise because we've suppressed the marketplace, and if we want to solve these problems, we have to allow the market to exist and get the incentives right.
Thank you, Dr. Goodman. Mr. Quincy.
Do I use this, or is somebody else going to move the slide? Okay, thank you.
Can you push the button and turn your microphone on there?
Yeah. Thank you. Chairman Lankford, Ranking Member Spear, and members of the subcommittee, thank you for the opportunity to testify today. My name is Lynn Quincy. I'm a Senior Health Policy Analyst with Consumer Reports, and I have personally led a number of research efforts designed to test consumer disclosures. I'd like to start off with a profound apology for being late. There was asymmetrical information in the marketplace, and I did not realize I need 15 minutes to get from the curb into this room. So sorry about that. It's really a pleasure to be here today because improving transparency of quality and prices in the healthcare marketplace is an issue that we can all get behind. Better transparency is likely to mean greater consumer engagement, empowerment, confidence, and better health from improved practice patterns by providers and better informed consumers. However, I want to offer two cautions as part of my testimony today. One is we can all point to consumer information or a disclosure that has confused more than helped. So I'll give you as an example, HIPAA privacy notices have not proven to move the market very much, but those mile per gallon stickers on cars are fabulous. So when we talk about transparency, I want us to talk about getting it right. Can I have my next slide? This, click one more time. So as an April Fool's joke, one of the barriers to getting transparency right is that the information is too dense. As an April Fool's joke, an online retailer changed their terms and conditions text so that people who clicked yes would be selling their immortal souls. Click the next one, please. 88% of the people at this shopping site wanted to get on with their shopping, and they agreed to sell their souls. So I think that's not the outcome we're looking for. There's other problems. May I have the next slide, please? Which is, if you have transparency, but you don't know which bit of transparency to believe, you have not yet been helped as a consumer. I borrowed this slide from an excellent presentation by Kaiser Health News. And as you can see, there are myriad outfits out there, including Consumer Reports, measuring hospital quality. Next slide, please. They may not agree on how with the quality of a hospital. So again, we have not yet helped consumers. In my written testimony, I provide a much more detailed examples of how we go about getting transparency right, and I hope that will be part of the focus of this subcommittee. But the good news is this is achievable. We have lots and lots of information about how to do transparency right by consumer testing, other things that I won't get into, and we know that the benefits of doing it far outweigh the costs. So there's actually no reason not to do more with transparency in all these realms. So that's great news. Let me move on. The one thing I want to be careful about, though, is to not overstate what we get when we improve transparency. And I specifically want to talk about price transparency. We do have a market where there is no third-party payer for health care in the United States, and that's our 50 million uninsured. And they would sit here and tell you that the market is not working right for them. So there's two lessons we can extract from this. One, better price transparency by itself is not going to fix our problems. We need to do more than just make prices more transparent. Second, what was my second point? Well, I mean, I'll look at my notes. Well, all right, let me stop because I'm running out of time. In my testimony, I talk about some of the reasons why price transparency alone isn't going to achieve all the policy goals that we wish it would. A key one is that right now, consumers actually associate higher prices with better quality. So they're inclined to, if they were given price information and that was the main determination of how they were making their choice, they might actually choose the higher price services, driving up healthcare costs, which is the outcome that we don't want. Again, we have a ready solution, which is to do that original fundamental research which says, how do we talk about prices with consumers? Perhaps we really don't want the price, but instead we want the value. We need to put value measures in front of them so that they don't assume that higher price is a signal for higher quality, but instead we've really told them something about the quality of the services that they're shopping for. We also have to keep in mind that many services are not shoppable. It's the opening statement by Mrs. Spear told us that, there's lots of services out there for which you really have to rely on your physician to navigate those treatment choices. I will stop here, and I really look forward to the discussion. Thank you.
Thank you. And thanks to all of you. Dr. McCary, let me ask you a little bit about the Federal Registries. You bring up a unique issue in healthcare right now, and that is the transparency side that all of us have talked about. Why? Why aren't the Federal Registries public? Why can't a researcher get those and have comparables? I understand why the patient's name is not connected. That's obvious. But the ability to be able to compare hospital to hospital, procedure to procedure, and I've even dealt with some researchers that want to just study across a particular effectiveness of a certain procedure that happens and what's the mortality rate, and they're not able to be able to research that as well. Why? Can you hit your microphone button there as well?
Okay, thanks. I honestly think there are no villains in this game. It's just that historically we've had very raw and unsophisticated metrics that run the risk of punishing those that take on the high-risk cases and rewarding those that discriminate against them. I appreciate that as a pancreas surgeon that takes on some of the most high-risk cases that no other surgeon in the country will touch. I appreciate the need for risk adjustment. But the databases have matured now. We can give good patient outcome results using physician-authored formulas that come from the American College of Surgeons that appropriately account for a patient being obese or diabetic or elderly or having other risk factors, and come up with a composite score or a performance level. And that makes this an exciting time, because if we handle the data appropriately, which many groups can, we can learn a lot from these databases. If you're going to deliver a baby, do you want to know which hospital has a 40% C-section rate in Washington, D.C., and which one has an 8% C-section rate? I think fundamentally, as this data is being tracked, and we can, in a mature way, come up with outcomes for each hospital, we as a society are faced with the dilemma: do we believe the public has a right to know about the quality of their hospital? I think they do.
Dr. Goodman, you have wrote extensively and talked extensively about HSAs and about some of the funding mechanisms of individuals engaging into their own health care choices. You talked as well about medical tourism. The hospital that I mentioned earlier in Oklahoma City, that is a flat rate price that lists their prices and puts them out there. When I spoke to the physician there, first thing he said was, when we opened and put our prices online, we were surprised to know that the Canadians showed up first. And that their hospital was flooded with Canadians coming because they saw the price online and made the flight to save the time to be able to do it. Obviously, those are wealthier individuals that are able to make that transition. But the medical tourism of moving around once people saw the price does affect things. But they also want to know the quality. It's not just the price, but it's the quality. So engaging in the price aspect of it and the individual being involved, what have you done in your research on that?
I think the most important change we could make in our healthcare system to encourage price competition and quality competition would be to allow everybody to have a flexible health savings account. Before there were health savings accounts, basically the tax law encouraged us to give all our money to the insurance company, because all that could be paid by employer with pre-tax dollars, and any money we put in a bank account got taxed. Now we do have the health savings account, and 27 million Americans have them. But the rules are very restrictive. We should have a very flexible account that wraps around any third-party plan, and then let the market determine how much should be paid by the patient and how much by the third-party payer. And I think that most primary care and most diagnostic testing, along with some other services, ought to be paid for by patients from an account which they own and control. And that would radically change the market for primary care overnight. I mean, you'd see the number of walk-in clinics would triple and quadruple just within weeks if people could go in those clinics and pay the market price. And that's the best way, by the way, to control cost in Medicare and Medicaid.
Okay. I have a friend of mine that told me about a week ago that she went in for a diagnostic test. The diagnostic test, they started the procedure as a routine thing for her. She has not been to the doctor at all this year, and so asked about what the price would be. They said, we don't know what the price would be, and went through the whole rigmarole, figured out what it would be with her insurance, and said she'd pay $1,600 because she hasn't met her deductible yet. She said, well, what if I just pay cash, and we don't file this with insurance at all? They said, oh, that price we can give you, it's $600. And it was this incredible shift that has occurred in the way the prices work, and that we've got to find some way to be able to get plain prices out there and so that people can engage with that. With that, I'd like to yield to the Ranking Member, Mrs. Spear.
Thank you, Mr. Chairman. In Mr. Brill's article, he spends a lot of time talking about this foreign object called a charge master, which every hospital has. It's a book of fiction that only applies to people who come into the hospital who don't have insurance, who aren't Medicare, who aren't Medicaid, and they get slapped with these exorbitant prices for services that are rendered, much like the example you just used, Mr. Chairman. So I guess I'm interested in knowing what your opinions are about these charge masters. Should we just get rid of them? I mean, they only penalize those who are uninsured, those who are working poor, those who aren't eligible for Medicaid, aren't eligible for Medicare, and don't have health insurance. Any comments?
Well, yes, they are fiction. And they're a holdover from the old cost-plus system where all those prices figure into how the hospital gets reimbursed in one way or another by Medicare and Medicaid and then by the private insurers. No, it would be much better if hospitals competed on price and competed on quality. But right now, all they're doing is maximizing against reimbursement formulas. And everything they do on their charge master is designed, there's some computer program helping them use that to maximize against the third-party payer formulas. So it's a very inefficient system, and the uninsured patient who gets caught up in it is confronted with that bill and thinks those are real prices. They're not real prices, and nobody should pay them, quite frankly.
Dr. Makary, you put up a slide that I thought was quite informative on laparoscopic surgery and how those that still use open surgery versus those who use laparoscopic. Is there any distinction being made between rural and urban? Are you seeing more laparoscopic in urban and less in rural areas?
Interestingly, we don't see a difference in rural versus urban areas. We don't see a difference in large academic versus smaller hospitals. It tends to be a regional variation. It tends to be the way somebody is trained. It tends to be the preference of the individual provider, even within an institution. Some providers may do it open and some laparoscopic.
Older physicians using open versus laparoscopic?
We didn't study the age of physician, but we know that younger folks, especially those that grew up with Nintendo and video games, are a little more skilled with laparoscopic surgery.
Okay. None of you really kind of focused on this issue of ancillary medical services in which a physician has an interest and then refers patients to them. I think Atul Gawande did a piece called the cost conundrum some years ago and looked at El Paso, Texas and McAllen, Texas. And the Medicare patient in McAllen, Texas, we were more than $14,000 was being spent per year on them, only $7,000 a year on an El Paso Medicare patient. And when he really digged down, he found out that it was the physicians who owned the hospitals in McAllen, Texas, that had, and the home health services and the other ancillary medical services that was causing this twofold cost differential in Medicare. Do any of you have comments on self-referral or the fact that physician ownership of these services has an impact?
Well, I think Gawande sort of missed the boat on comparing those two cities because while it's true that Medicare spends a lot more in McAllen than it does in El Paso, it's also true the private sector spends a lot less in McAllen than in El Paso. And what I think is going on is that almost everybody in McAllen doesn't have any private insurance, and Medicaid in Texas pays very little. So I think what they're doing is they're just shifting every cost they can to Medicare. Bad for us as federal taxpayers, probably good for them locally. The whole issue of what does the doctor own and what can he use, I think the incentives are very perverse. I don't really think the best answer is to tell the doctor he can't have that kind of equipment or he can't own it. I think the best answer is to encourage a real market and let competition determine what services he's going to offer and what services he's going to contract down.
I'm running out of time. Ms. Quincy?
I think there's a number of studies that confirm what he found, which is that when you have physician ownership, you do see more tests. You see that ancillary service used much more often. It could go up by like 200% the usage, and it does cost more. The Affordable Care Act does include a transparency provision that says that doctors, if they are self-referring, they have to reveal that. But I suspect that will be necessary but insufficient in this case, that we need more than just transparency.
Sort of like selling your soul on right?
Well, we hope
it'll be read, but it won't.
If this subcommittee would just require testing of that disclosure.
Thank you. My time has been depleted.
Thank you. Dr. Gosar.
Well, thank you very, very much. Dr. Markey, just to let you know, I'm a dentist. Very different parameters versus physicians in cost escalation. Definitely a little expensive to provide, but very different tracks, medicine versus dentistry. I'm also from Arizona, a very aggressive state dental board versus a very lenient medical board. So I think you know where I'm going to go on this. You've seen patients that have seen and are going to see an inferior doctor. There seems to be some type of aspect in which we're protecting bad doctors. Can you elaborate on that?
Right now, if you lose your license in a state, the common next step is that the physician will jump to another state and apply to get a medical license. Now, the state can inquire with the National Practitioner Data Bank whether or not there's been a prior action. But in doing the research for the book on Accountable, I learned that some states don't want to pay the fee even though it's less than $10 to run the inquiry. They argue they can't afford it for all their doctors. So about half of all physicians who lose their license because of some atrocious immediate suspension because of a category called immediate harm to the public, they go to another state and set up their shop. And it's probably one of those things where if we just had more coordination of care, we could prevent those thousands of patients that are seeing these doctors from the risk.
And isn't there a timely factor here? I mean, it almost has to be an outrageous, egregious action to even get it on to the medical or into the public. Isn't that true?
Absolutely. And most of us will be sued at one point in our careers. Being sued is certainly not a marker of quality, even though it's reported to the data bank. But the category immediate loss of license because of a threat to the public, that's something I think should have coordination, just as the FAA does for pilots.
I agree. And you argue that doctors spend so much time or very little time now with patients. So it's almost what they call a patient shuffle. A churning mechanism, so to speak. Can you tell us that, from the perspective of docs, I talk to a lot of them, they're burned out based upon the way the parameters are being compensated. Because then I'm going to come back to you, Mr. Goodman, because I want some follow-up questions in regards to that. Can you tell me a little bit about that mechanism and the way physicians are burning out?
46% of us are burned out, according to a National Mayo Clinic trial that just came out last year. Now, what drives doctors to burnout is not the patient care. They love the patient care. We love the patient care. It's the quotas that we get harassed with by emails on a monthly basis. It's the targets. It's the pressure to see 15 patients in a 2-hour window. This is not the type of medicine that my father practiced in his career, and it's the sort of thing that is resulting in many doctors not recommending the profession to their offspring.
So, Dr. Goodman, I mean, we've talked about market factors, and something that's not been put out here is the government is part of those market factors because since the conception of rates from HHS and CMS, we have an artificial market, and I think the government plays a part in it because all we're doing is cost shifting. Because when you look at our medical aspects, we have lots of specialties, no primary care docs because there's no reimbursement mechanism. We've priced them out of the aspects. Part of that aspect is sharing of information, particularly with our third-party payers. I think they're part of the solution, but right now they're part of the problem. They share our information. Can you address maybe looking at the true cost of medicine and looking at insurers not being able to use collaborative actuarials?
Yes, I think that's bad, and I think your premise is correct. The reason the market has been suppressed is because of government action, much of it at the state level going back for decades. the answer is to find ways to liberate the marketplace. And I think the walk-in clinics, for example, perfect example. In Dallas, Texas, if you have a earache or sore throat, you walk into the Minute Clinic. There's a posted transparent price at $75. But Medicaid only pays half that. So none of the Medicaid patients can go to the walk-in clinic. They all have to go to the emergency room or to the community health center, where they will wait a long time for care. So I think a very good thing to do in Medicare and in Medicaid is let those patients pay the market price, whatever it is, and reimburse at that market price, because it's a lot cheaper than what the doctor is charging or the emergency room, and we would overnight greatly improve access to care for the low-income population.
Okay, I'm running out of time. I'll wait to my second round.
Thank you. Very distinguished ranking member of the full committee, Mr. Cummings.
Thank you very much, Dr. McElroy. I listened to what you said a moment ago. That one of your patients said the parking. Let me tell you something. As a resident of Baltimore for 62 years, and as one whose a family member just had surgery at Hopkins, people come to Hopkins for more reasons than parking. It is the greatest hospital, in my mind, in the world. So you come from a very prestigious hospital, and I'm very familiar with Hopkins. It's smack dab in the middle of my district. I was trying to size up your testimony with Ms. Quincy's. Because she says something that's very interesting. You talk about transparency, but sometimes I think about the people that come to my office, and I could give them data, but I want to make sure they're not so overwhelmed with data, or that they even know how to read the data. There are people in Congress that don't know how to read data with law degrees. So I'm just trying to figure out how do you size that up? You follow what I'm saying? In other words, I want to be practical. Sometimes policy is not connected with practicality. So, but I agree with everything you said, except the parking. But help me with that. You follow what I'm saying?
Absolutely, and I agree with you. Now, there's a good model. The heart surgeons in the country.
And you're going to have to talk fast, because I got to talk to Dr. Goodman.
Got all of their data, their outcomes data together, and delivered it to Consumer Reports that put it on their website. They've got the brand recognition, and you can look up the star rating for our heart center in the United States. So it is possible to distill it down in a user-friendly way to patients.
Just like the
C-section rate.
Dr. Goodman, you argue that in place of the ACA, healthcare reform could be better achieved by depending on informed individual consumers who would be responsible for shopping for price and quality care, and of course the bill. Mr. Goodman, you call that skin in the game. Dr. Goodman, I'm sorry. I call that shifting costs to consumers. As seen in this slide, where's the slide? Somebody put the slide up. Medical expenses are the #1 cause of bankruptcies in America. According to the Administrative Office of U.S. Courts on behalf of Federal Judiciary, 1.3 million petitions for bankruptcy were filed last year. 62% of bankruptcies are the result of health-related illnesses or medical bills. 69% of those had medical insurance. And I'm going to tell you, when I practiced law, people were very reluctant to file for bankruptcies for a lot of reasons, and usually it was a last resort. So, Dr. Goodman, you suggested that a uniform fixed dollar subsidy of $2,500 for every adult and $1,500 for every child is appropriate. Now, I wonder, what would you say to the millions of Americans who have been driven into bankruptcy because they already had more skin in the game than they could handle? What about them? And also, I also want you to comment on the 22.3% uninsured rate in your area and how that plays in with all you're saying.
Okay. I believe in universal coverage, and I believe the Federal Government ought to make it possible for everyone to have health insurance, affordable health insurance. I think that could be done with a refundable tax credit the right way instead of the bizarre way that we're doing it under the ACA. Skin in the game is just not really a phrase I ever use. What I believe is that there's a certain amount of money that people are going to have to spend on health care, and it should not all be given to the HMO. Because if it's all given to the HMO, then it will decide how the money is spent, and I think patients need to play a role in deciding what kind of care they get. I think the bankruptcy study you all are referring to is junk study, and it's been looked at, and there are better studies. And there are people who go bankrupt for medical bills. There are people in Canada who go bankrupt because they have medical problems. And the bankruptcy rate in Canada is not that much different from it is in the United States. Not a good thing, but that's a distraction.
Well, I don't like distractions. I would like for you, since you have better numbers, I'd like for you to get them to us, because we need to get to the agencies that's putting this out to make sure that they are not putting out untrue statements.
I'll be happy to do that.
All right. Thank you very much.
Thank you. Let me submit to the record, there is a study that's been put out by Diana Roth that deals with that same number. That's a Department of Justice study and the Federal Reserve listing on it, dealing with that, and I'll be willing to share it. Let me enter it into the record as well. Get a chance to talk through that. Mr. Woodall, recognized for questions.
Thank you, Mr. Chairman. I appreciate you all being here. This is one of the nearest and dearest issues to my heart. I just am curious, as we're debating so much in Congress about what the future of the American health care system is, do any one of you agree that the health care system will provide the kind of care that we want it to provide at a cost that we as a nation can afford if we don't improve transparency in the process? Can we keep going, Ms. Quincy, as we are, or must we do better?
We must do better.
Dr. Goodman, you would certainly.
Yes, but I think that forcing transparency on the system without changing what the third-party payers are doing is not going to change very much.
I certainly agree with you. In fact, I might define transparency as eliminating third-party payers from my life so that I can actually experience those costs. From a practitioner's perspective, Doctor, any belief that we can get by with the same amount of transparency or less going forward?
No, I think the only way to improve the health care system is to get at this 30% of it that may be unnecessary.
I certainly agree with the ranking member of the full committee. You can get overwhelmed with data. I have a medical savings account, and I'm out there making tough decisions. I'm not a doctor. I'm a lawyer, and I've got to go out and sort these things out. I'll confess, Ms. Quincy, as much as I fail to agree with so much of the policy statement that Consumers Union puts out, I love your magazine. And probably every day in the school library from age 14 to 18, I read every copy that came through. And the biggest purchase in my life at that time would have been an automobile. And it's complicated. It's kind of a life and death issue in some ways. Something looks really nice, but it turns out when it hits a curb, it falls apart and your head goes through the windshield. And you all helped me sort through those life and death decisions. Complicated, big dollar decisions. Sometimes folks chose the less expensive, more dangerous varieties for their life. Other folks chose the more expensive, safer, and bells and whistles along the way. Why won't that model work in a healthcare world?
I think there's a couple reasons. One is we're talking about purchasing a product where the spending in a year could exceed $100,000 as opposed to the $10,000 for a used car that's being spread across 5 or 6 years. So, and we're also talking about absolutely essential purchases because they alleviate pain, they increase quality of life, they prolong life, whereas in some cases you may have an option other than a car. You may have public transportation. So I think most people feel that this market is different from other markets where the commodities are more fungible.
There's no question that I think you're right that most people do feel that way. I just question whether or not they're right. You've made the very accurate point that some of these are more expensive than others. You know, I use you for tooth whitening toothpaste as much as I use you for automobiles. You have managed to do things at all ends of the consumer spectrum today. I don't know why we wouldn't succeed at that going forward. I think about my grandparents who died surrounded by people who loved them in their home. There was a choice about health care. These were not life and death decisions about which they had no choice. These were life and death decisions about which they had great choice, and they made those decisions. I have a great fortune of having physicians in the family who help guide us through those. I do worry about where folks go to get that information, but Dr. Goodman, I think about Medicare Part D, for example. I wasn't in Congress then. I would have voted no then. I'm not in favor of new federal entitlements. But I remember folks saying very much what Ms. Quincy just said, is that these are life and death decisions, these are very expensive decisions, and these are too complicated for the American people to sort out. I think the data today suggests that Medicare Part D has been successful with individuals sorting out their own decisions.
Well, it has been. It seems enormously complicated, however. Remember, we still have third parties and the government determining everything. But the Minute Clinic, that's a real free market. And nobody tells the Minute Clinic what it has to make public and what it doesn't. But if it doesn't do it in a way that people can understand, no one goes in the clinic. So they're making lots of money. They're spreading all over the country because they give people information in a way that they can understand. And by the way, all the records are electronic and they can prescribe electronically.
No question, Dr. Goodman, it's complicated, and no question, as Ms. Quincy pointed out, it's hard. Most folks can't fathom how we can get it done. But I think about folks in the actual provision of the business, doctor and my family members who are docs and docs in my communities, people who are really questioning whether they're going to stay in the business or not, and more importantly, questioning whether they're maximizing their ability to make a difference in people's lives. And at some point, the system we have today is actually diminishing the quality of individuals' lives and care rather than improving it. Have you had a similar experience?
Absolutely. And there is a debate going on right now within U.S. hospitals. Should we pay doctors a relatively flat amount, maybe with a small bonus for innovation or quality, or do we give them gigantic bonuses, $250,000, $500,000 for pure volume? And the CEO of the Cleveland Clinic and the head of Kaiser have come out saying that they believe it's unethical to pay doctors based on volume. Other hospitals are going the other direction, and I think that contributes to the doctor burnout.
I thank you all. Thank you, Mr. Chairman.
Thank you. Mr. Horsford.
Thank you very much, Mr. Chairman, and I appreciate this panel and the very important information on the provisions of the Affordable Care Act that are being discussed today. One of which I want to touch on right now is the Summary of Benefits and Coverage Program created what is an unprecedented standardized method of communicating health plan information to the over 170 million consumers enrolling in private health coverage. The SBC requires providers to give consumers information about health care plans in a uniform layout and in terms they can understand, meaning consumers can make educated decisions about which plan is best for them. And I know as I talk to my constituents, as I talk to small business owners, this is something that is very important, is having people be more educated about the decisions they make. And we're fortunate to have a witness who is an expert in this, Ms. Quincy. I understand that you, while working with the Consumer Union and the National Association of Insurance Commissioners, conducted extensive research both to determine what information would be most useful to include in the SBCs and to determine how effective the programs were after implementation. Is that correct?
Mostly, yes. The Affordable Care Act itself included some requirements that we started with as to what should be in the SBC. And if I have a chance, I'll tell you about a key one that illustrates a lot of points being made today.
So please elaborate. What are some of those features? Yes.
Well, one thing I'll say to start is that this particular provision is absolutely beloved. It ranked higher than subsidies for health insurance premiums when Kaiser Family Foundation did a poll, because consumers do feel they need help picking among health plans because the information isn't standardized. But I know we're moving quickly. If I could have the next slide. One of the required features, and one that where the consumer testing produced the greatest surprise, was around this page, which is a page called Coverage Examples, and it includes 3 pieces of information that consumers have never seen before. One, it shows how much medical care costs for the medical scenarios displayed, and that's something that consumers don't know. They don't understand how truly expensive medical care is, and that's why in today's market they might buy a policy with a $20,000 annual benefit limit, not realizing they're very underprotected, may end up in bankruptcy. Second, it gives a bottom line for what all those myriad cost-sharing provisions actually mean to the consumer. By the time you weigh the deductible, cost-sharing, blah, 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 what does it actually mean if you have a baby? What do you have to pay? Consumers can't figure that out. I couldn't even figure it out when I was trying to create these for testing. Third, and the surprise, it shows what the plan pays for coverage. For that medical scenario. And that may seem like a residual. It proved to be very important because when consumers do not want to shop for health insurance, they'd rather shop for cars. It's more fun. And they kind of forget of the value associated with having health insurance. And when they saw on this breast cancer example, which is what we tested and is not in the form today, a $100,000 service for a year, they went from saying, I'm not going to buy that plan because that deductible looks so high, to saying, you know what, that's chump change compared to what that plan is paying on my behalf. And I can show you the videotape. So the bottom line here is, A, consumer testing tells us what we need to know, and we shouldn't be guessing. B, it's powerful. We could be moving the market just by working with this form and doing more with it. I'll stop there so I don't use all the time. Thank you so much.
And so in your opinion, and based on the testimony that you've given, would you say that the SBC is an effective criteria to meet those improved communication and education provisions of the law?
I think that the SBC fills a great need. I actually do hope it will be improved over time. I think that like one thing that did not happen is the form was not designed by a designer. And I've told HHS that we need to get a designer in here to tune it up a little bit. That's the nature of disclosures. Ideally, they improve over time. But there's a report in my written testimony that I linked to that says how well received this was by consumers. So we're doing great so far.
Any other recommendations or steps that you think this committee should take?
Well, with respect to this form in particular, yes. The form that consumers see today only has 2 of the 3 examples you see before you. It's missing the expensive breast cancer example, and that was the most impactful, and it needs to be brought back. Second, a change was made at the regulatory level to go from real-world prices to Medicare prices. So you'll see that having a baby is $10,000 in this slide. If you go to the next slide, or the previous one, whichever one has, now it's $7,540. That's not a real-world price. So there are, and I can afterwards give you a whole list of things I would love for this committee to do.
Mr. Chairman, may I ask, do we have a copy of those slides?
We can certainly get a copy of those slides, and they'll be included in the record as well.
Thank you very much.
Absolutely. Ms. Lujan Grisham.
Thank you, Mr. Chairman. And I have to say that when you come into these committees this late, you often end up repeating many of the fine points and questions. I'm actually going to dovetail on my fabulous colleague, Mr. Horsford. And Ms. Quincy, I really appreciate describing that we've got great first steps, including making sure that we have more transparency and we are driving folks to a consumer-based marketplace through the exchanges and the Affordable Care Act, but that healthcare information is complicated, and that even the folks who have tried in a variety of before the Affordable Care Act have made many attempts to make billing information. I mean, anybody who's tried to read a Medicare statement, for example, it used to take me months to train doctors and other healthcare professionals to be able to navigate explanation of benefits and Medicare bills to figure out whether or not those Medicare beneficiaries still have to pay, have reached a deductible, what that 20% is or isn't, whether it's a covered service. And so it is. It's very complicated to navigate, and I think that these are important first steps. But I want to talk to you, Mr. Horsford got you to identify other things that we could be doing to make this more transparent, which will make consumers better able to make productive choices. Let's talk a little bit about how that would translate into creating better price structures and helping consumers help us make sure that we don't have price discrimination and overcharges in the system. Do you have any suggestions about how we might do that?
Yes. some, I think, low-hanging fruit, if you will, things fairly easy to achieve. One of the things that stops consumers from using the price information that is on the marketplace today is it's by CPT code, so a single procedure. And they don't bring the knowledge to the table that tells us what's the full bundle of procedures that I need to know. This is why they might get tripped up with respect to out-of-network charges, because they don't realize there's an anesthesiologist charge that goes with this surgical charge. So anyway, we need to provide them with information that's already bundled into the entire set of services that they're going to need. Second, we've got to link those things with value. We should not be showing price information alone. And that's pretty tricky, but I think it can be done. I also think that underlying all of this, like the testimony of others, is great information about comparative effectiveness. What are the right treatments? What is, when you're choosing among treatment alternatives, you frankly don't want to do it on the basis of price. You want to know which is going to give you, the patient, the best outcomes. And we have that information in some places, but not where we should. It's shameful that that information is not always available to us. I'll stop there just so you have enough time.
And thank you very much. And this is for anyone on the panel. And again, I apologize if these issues were covered before my attendance here at this morning's hearing. And again, I'm in favor as much transparency, and not so in favor that I think this is oversimplistic to say that just a free marketplace kind of transparency environment makes this easy. As I said, I come from this at experience helping the Medicare's Senior Saving Medicare projects, Operation Restore Trust. We're really looking at ways to really understand what's going on. Long-term care ombudsman programs, helping folks understand what services they ought to be getting in nursing homes. And it is so complicated that the best way I could do it would be to train accountants and really looking at folks. I am not, for example, able to figure out when my engine light goes on just exactly what's wrong with my car, nor am I able to navigate it when the mechanic tries to explain it to me. And when you're sick, you are not in a position to shop, and Americans are sicker than everybody else. And I just like these responses that we're not dealing with the patient population, no matter how sophisticated we are, that can navigate fairly just because people are more transparent. Do you disagree with these statements, and why? Anyone on the panel?
Well, I think the best way to get transparency is to do something like what Walmart is going to do with all its employees. It's going to have 7 centers of excellence. You want to get on a plane, go to those centers of excellence for your elective surgery. They'll cover all the costs. If you want to go to some other hospital, you have to pay the extra marginal cost. So that makes every employee of Walmart very aware that there's going to be an expense for going to another hospital or another health center. And then once they do that, in places where there are a lot of Walmart employees, the other hospitals are going to say, hey, we can't get customers here with these CPT codes that nobody understands. So if we want to compete with the Mayo Clinic and other health centers, we better come up with a package price that people can understand and quality measurements that they can understand. It's on the provider side that we're going to solve these problems, not on the buyer side.
Thank you, Mr. Chairman. My time is up, so I'll yield back, but there's plenty more to debate on this issue. Thank you very much.
Well, good. We'll hang around for a second round of questions if you'd like to be able to stay engaged in that as well. Let me come around for a second time around on a few things. For all of us, we want the best in possible patient care. I mean, that's what this is all about. It's an individual, the best in possible patient care. It's also best possible price, not only for the individual that's paying it, but in the cases where the Federal Government's involved in health care, also for the Federal Government as well. But it's about the patient at the center core of this. Dr. Goodman, you've done a lot of work on cost issues. What would you propose as the most significant things that we could do that both improves patient care or takes good attention to individuals, but also good attention to price?
Well, again, I think we have all of these clinics that are opening up, all the minute clinics, the walk-in clinics. We have the doc in the boxes. We have the freestanding emergency room clinics, and they really are in a free market, and they do offer posted prices. And the mistake we're making in our public programs in Medicare and Medicaid is that we're not allowing the patients to pay those prices. Instead, we dictate what Medicare is going to pay. We dictate what Medicaid is going to pay. We don't need to do all that if we have a market that's functioning and if the price looks like it's way below what we would otherwise pay. So there are a few simple things that we could do that I think would greatly expand access to care, particularly for low-income folks.
All right, but that's for basic data care. That's the flu, that's an earache, that's a broken bone. That's for simple things. What about when we step into more complicated?
For more complicated, just to pick up on the Walmart example, other employers are looking at this structuring their insurance so that if you go to a high-quality, low-cost facility, they pay everything. You want to go someplace else, you pay the extra cost out of your own pocket. And then that puts enormous pressure on the provider side of the market to begin to compete with bundled prices and with quality information. And I think you're going to see a lot more of that. Right now in Dallas, Texas, there's not a single hospital that's not in Blue Cross's network. So it doesn't matter how good the hospital is, how bad, what its mortality rate is, they cover everybody. That's not the way to get to where you want to be.
Right. What about for the individual? I mean, all those assume an employer or a larger company that they're involved in. What about for a small business owner, himself and his wife or her husband own the business and that's it?
Well, I believe in the very flexible health savings account that will wrap around any third-party plan. And I really think the ideal way to structure it is to put enough money into the account so that people can pay for their primary care, for their diagnostic tests. If something really expensive happens, then the plan pays for it. But carve out whole areas of care, especially all the diagnostic tests, and say, look, you can have this. We're not going to argue with you about how often you can have a mammogram or a pap smear or a PSA test. We're going to put money into account, and you decide how often you get these, and you decide if you can find a better rate and higher quality testing. That would change a lot.
Okay. We're all in the middle of the transition to the Affordable Care Act. And we're all kind of watching the administration right now trying to implement things. There's a lot of guesses on what it will look like, both on price, on insurance, and how it's going to work, and exchanges, and state versus federal. I mean, all these dynamics are out there. You're doing a tremendous amount of research in this as well. Based on just typical behavior of individuals, there is this sense that individuals will stay out of the insurance market until they're sick because they have guaranteed coverage at this point, and that they will then step in and pick up coverage as soon as they become sick. Are you tracking with that, or where are we on any of that? Do you think that will affect premiums? Do you think that's a likely behavior?
I think it's going to be a huge problem, and it's going to be made worse if the application form is 21 pages long. And it's going to make worse if the HHS continues to not use systems that are already out there. eHealth has insured 3 million people on a private exchange. HHS is not using that private exchange. I think that's a huge mistake. They're going to go hire navigators who will not be insurance brokers. They have to be trained. And the fines for being uninsured are small, and they don't apply to millions of people. And it appears that the IRS can't do much to enforce them except withhold refunds. And so the insurance companies are very, very worried that only sick people will sign up, and it's a legitimate worry.
Okay. With that, I yield to Mrs. Spear.
Thank you, Mr. Chairman. Dr. Goodman, you are an unabashed proponent of HSAs. We've heard it like 5 or 6 times this morning. The GAO has indicated that the average adjusted gross income for those aged 19 to 64 who have either made a contribution to or withdrawal from an HSA have an income of about $139,000 a year compared to the average filer who's making about $57,000 a year. So the persons who are accessing HSAs are people who have more money, people who have the ability to squirrel away money. So I don't think HSAs are the answer, and that's the model on which you describe much of your commentary. So I guess my question to you is, if we don't have HSAs, if the majority of Americans don't access HSAs because they don't have extra money, we've got lots of unemployed people, we've got lots of people who are just making it, who don't have, $5,000 to set aside in an HSA, how are we going to make sure that they have health coverage under your concept?
Well, I'm not talking about extra money. I'm talking about the money that's put aside for them by an employer or by the government and I'm saying it should not all, in my opinion, go to the third-party payer. But I'm perfectly willing to allow the market to work, and if people want to join an HMO and give all the premium dollars to HMO and let it make the decisions, I'm willing to allow that to happen. That's basically what happens in the Medicare Advantage plan. But I'd like to see people have the option not to give all the money to the insurance company, to retain part of it in an account that they own and control. And I would especially like to see the opportunity for people to carve out whole areas of care that they will be responsible for. And the employer puts money into the account. And I think this could be a real interesting way to approach the whole issue of chronic illness. In the Medicaid program, of all places, we have something called cash and counseling, where the homebound Medicaid disabled are managing their own budgets.
All right, thank you. I need to go on and ask Ms. Quincy. Ms. Quincy, what has your experience been with these HSAs and high deductible plans and their ability to really cover people?
I think that the evidence associated with these plans completely comports with what theory would predict. They are excellent vehicles for people who are either very well off and or healthy. In fact, there's some data from the IRS that indicates that they're actually used to do long-term retirement savings, because it's another tax advantage way to save for your retirement. And there's nothing wrong with that. I do think we need to be careful and state so that we know it will not solve all of our health issues. I think there's a role for it. You've already made the point better than I have, that there's many, many families for whom they are very cash strapped. They have no liquidity, and they may be also time constrained. They are just not in a position to shop all these services and manage this large account. I just think the evidence is overwhelming that that's the case.
All right. I have a question for each of you now. You know, there's still a lot of pushback on the Affordable Care Act. There's still people that want to undo it. I think it's counterproductive at this point. I think it's here to stay. I think that what we should be doing is making sure that it works. And I know for some of you that's a hard concept to put your arms around because you just don't support it. But having said that, there are issues that we have to address in the Affordable Care Act around cost containment, because the bill does not address that. And our job in Congress right now should be looking at where are the areas where we can impose cost containment, because a fee-for-service model is antiquated. So with that, Dr. McCarry, let's start with you.
I appreciate your comment, Congresswoman. Even the authors of the Affordable Care Act, at the time that it was passed, said that more work needs to be done, and it was recognized that it was not all-inclusive of the changes that need to be made in health care. And, of course, no law is ever perfect. Right now, dealing with the cost crisis, it appears that transparency is the most common sense, logical, and low-cost way to allow the free market to come around outcomes. But if we just talk about price transparency, I do worry it's a very dangerous business, because it will simply force the market to provide the lowest price. We've all talked about the importance of value and outcomes. But where are these outcomes? They live in these registries, and I think if Medicare is going to reward things, they should reward registry participation and public reporting in these registries.
I'm going to ask unanimous consent to extend for another minute to allow the folks to be able to answer that question.
I personally put together something called the Health Roundtable, and it includes the Business Roundtable, includes the drug companies, insurance companies. And basically, I said to them, I don't care where you were 3 years ago. You know, some of you supported it, some of you didn't. But I used the very words you used. You know, it's here. We got to find a way to make it work. So you all know better than Congress knows where the train wrecks are. Let's identify them. Let's do this in a bipartisan way. So we'd love to have your input on this, because the one party can't do this next time around. It's got to be both parties.
Constraining health care costs is probably the thorniest dilemma that we all face. It's very complex and hard to do. I would actually be a bit more charitable towards the Affordable Care Act. It doesn't solve the problem, but it contains just about all the seeds of policy solutions that we would explore. I won't enumerate them here, even though I wish I could, but perhaps some of the later questioning we could dig into some of those provisions, like there's a new large payer, which we've all agreed is how you move the market by having large payers, rate review, and other issues.
Dr. Gosar.
I disagree. You know, I want opportunity and I want choice. And that's inherent to me, and I've done it for 25 years. I mean, I've built, you know, individual insurance models for patients day in and day out. So I want choice. And we can't solve this problem without involving the patient in this decision process. But the market is broken, and it's been broken from the government entity, it's been broken from the insurance entity, and it's been broken from the hospitals entity, all the way around. In fact, I always share this. Who's been on the government dole the longest for dictated health care systems? It actually is the Native Americans, and they're rebelling like light years. They do not want it. They do not like it. They want to have an individually based health care model. And they're exempt, by the way, from the ACA. And they're actually building some of the better health care systems around being built right now. So I want to look, Dr. Goodman, at the system, because I think we're built upon a flawed system based upon reimbursement rates dictated by CMS and HHS, as well going through an insurance industry. Would you agree with me that we can get back to some kind of competitive model and look at real cost instead of being able to cost shift? Because that's what we're doing right now. We're just cost shifting one to the next, to the next, to the next. And that's why you see some of this churning that goes on.
Yes, and I would go further, that we are never going to solve the problem of cost as long as you have every patient and every doctor having a self-interest in making spending higher. Okay? So if you want to solve the problem, we've got to get the economic incentives right, and health savings accounts is one way of getting the incentives right for the patient. And if you were more creative about that idea, you could do the same thing in chronic care, long-term care. So there are a lot of things we could do to give patients good incentives, and we can also do it on the provider side.
So, but you are your health care, are you not? You, the patient, you are your health care.
Okay.
You inherit your health, right?
All right.
And so you have to take an active participation in that aspect to drive it. So it's upon us to educate people in the genetics that we hold. Would you not also agree, Dr. Markey?
Yep.
And so we've got to involve them along those lines. Let me ask you a question in regards to, so we have this Affordable Care Act, so they say, and then we have an SGR. Does that make sense? How do you have an SGR and then you've reformed health care and you still have an SGR sitting out there because what you're doing is you're trying to reimburse physicians for not being paid appropriately? How does that work?
The Affordable Care Act addressed coverage in one way. It didn't address the SGR, which desperately needs to be reformed, and it didn't address the long-term cost crisis in a comprehensive way. So every physician in the country is united around there's only one thing that unites every physician in the United States, and that's we want the SGR changed.
Very, very, very interesting. And going back to choice, I mean, in the Affordable Care Act, what we're seeing in its implementations, you're seeing also in compliance, hospitals buying up private sectors, Dr. Markey. Does this help or hurt rural health care implementation?
Well, even before the Affordable Care Act, there was a trend which I've been concerned about, massive consolidation in health care. Do we want our cities and in some states controlled by one hospital corporation? There were 86 hospital mergers and acquisitions last year, representing a record in U.S. history. I think we all believe that it's going to hurt medical prices if there's only one player in town.
And so in the question Ms. Quincy was talking about large payer, that seems anecdotal, is this big move to big insurance, big hospitals, big medical groups. That's kind of contradictory to what we would solve it with, right?
Well, I like shopping for a cell phone with Verizon, Sprint, and AT&T. And if there were only one carrier, I guarantee the price would be higher.
That's what I found in dentistry, and I've found that in life as well. So, let me ask you the next thing is that talk to me about the new doctor. They're very different. You alluded to it in your conversation. We're producing a physician that's very heavy in debt. I mean, between $200,000 and $300,000, and so their opportunities are very limited in how they can repay that. Can you elaborate a little bit on that, Dr. Markey?
Doctors are getting crushed right now. Malpractice premiums are going up, their Medicare payments are going down, the overheads are going up, and then there's this pressure to do more with less. and that's why we're seeing this tremendous dissatisfaction. And I think we've got to look at the SGR. And, you know, these young doctors, they want to be honest and transparent because that generation has very little tolerance for a lack of transparency in other aspects of their life. So they're more likely to disclose errors to patients at the bedside, and they're more likely to look at national registries and say, why aren't these available to the taxpayers when they fund it?
Thank you.
Mr. Horsford.
Thank you, Mr. Chairman. Dr. Goodman, I do have to just respond a little bit to your statement prior. Replacing the Affordable Care Act with a model like Walmart has for a center of excellence, you know, it may work for Walmart, and I'm not going to, you know, make a judgment on that, but it's not going to work for millions of Americans in places like my district. And just by way of example, you know, my district in Nevada covers 7 counties. It's 52,000 square miles. It's both rural and urban. I have rural parts of my district that have no medical services whatsoever, so, or transportation, public transportation. And so to expect them to somehow, you know, navigate or be able to get to a center of excellence, you know, I would take some objection to. And small businesses who can't get the same volume prices as Walmart, I don't think would be advantaged. But I really appreciate, you know, my colleague, Representative Gosar, as a dentist, because I found that it's not the doctors per se that are the problem. It's, you know, the problem, in my opinion, are the insurance companies. Until recently, insurance companies spent a substantial portion of consumers' premium dollars on profits, including executive salaries and marketing. For example, in 1993, insurance companies typically spent 95% of customers' premiums on medical benefits, the so-called medical loss ratio. But by 2009, many insurance companies were routinely denying policy claims and dropping coverage for nearly 3 million Americans. That allowed them to stop spending so much on health care and start keeping a greater share of premiums for profits and executive salaries. And only about 85% of premiums were spent on medical benefits. By comparison, the government-run Medicare system put 97% of premiums into medical benefits. So according to one study, profits for the 10 largest U.S. insurance companies jumped 250%. 250% between 2000 and 2009. Now, I have no problem with the free market, and I think that people are entitled to a profit. But in health care, should we have 250% of insurance company profit when people do not have access to quality health care in America? Ms. Quincy, way back in 2009, was it legal for private health insurers to deny coverage and keep premiums for profit and executive salaries?
Yes.
Is it legal for insurers to do that, or has something changed now?
Well, many things have changed. Some changes have already occurred, like restricting the medical loss ratio to a certain range, 80% for individually insured and small group products, and 85% for large group products. And this is already in place. We can already see the evidence of how well this policy is working. But in 2014, of course, things change fundamentally, and people can no longer be denied or charged more because they have a pre-existing condition, mostly through no fault of their own. And that is the fundamental change that consumers really want to embrace. It's just not fair. It's unethical.
So is there evidence that the MLR is actually driving down health insurance premiums?
There seems to be. We just have one good year of experience with it so far. And also, when you look at MLR, you have to realize it's also being coupled with a much better rate review process. And those two things together seem to have, we observed again in our first year, that rate requests were being reduced or withdrawn. And there's a study out there that shows there does appear to be a benefit. And again, we're talking about greater transparency here between the MLR requirements and the rate review process.
Just quickly, Dr. Goodman's website suggests that the MLR will result in higher premiums and increased profits for insurance companies. What do you say to that?
Well, I think that you could it depends how real world you're going to get. In the realm of theory, you could say there's a scenario whereby MLR might increase profits. But in the real world, where we have competition among health plans, you can't arbitrarily increase your medical claims in order to increase your profits while still maintaining your MLR. You wouldn't fare very well in the marketplace.
Thank you. Quick follow-up question on that, Ms. Quincy. Just to clarify, are you suggesting that next year that premiums will be lower for individuals for insurance with that statement?
Well, if you're trying to get me to say that it
No, I'm just the statement about the MLR and that the premiums have gone down. Just trying to clarify, is that total premiums or just in that one area, or?
I'm so sorry. Are you asking me to clarify what we already know about premiums for the prior year, or you're asking about 214?
214, yes.
Okay. Well, we have lots of studies on this, and premiums will be going up for some people and down for others, and that's before subsidies.
Okay. Clarifying question as well. Dr. Goodman, you and Mrs. Spear had talked about something, and you brought up a cash and counseling program. I just wanted you to be able to clarify what that is and how that works. And then I want to see if there are any other quick questions, and we'll close down the hearing from there.
Well, this is a remarkable program because it deals with the most vulnerable of our citizens, and these are Medicaid disabled patients. They're allowed to manage their own budget. It was a program initially funded by the Robert Wood Johnson Foundation. And by the way, other countries are doing this too. And I was testifying about 2 years ago, and I brought this up, and Senator Rockefeller said, well, what does that have to do with health savings accounts? And I said, well, this is a health savings account for poor people. So after the hearing, he came up to me and he said, you don't understand. A health savings account is a Republican idea. And I said, well, let's call them Rockefeller accounts, and then we'll all be happy.
So how do they work, and where do they come from? How old are they?
Instead of the government.
This is a pilot that currently exists.
Yeah, in just about every state, I believe. Okay. And the patient manages money. And initially, it was just custodial services, but now it's real health care. And they can hire and fire people who provide them with services. And so if they don't like what they're getting from one provider, they can go to another.
Okay. Any other clarifying questions? You follow up on it? Ms. Quincy, Dr. Goodman, Dr. McCary, thank you for being here, and thanks for all you've submitted and the work that you put into this, both the books, the research people. Dr. McCary, you also, I saw an article that you put on the Wall Street Journal. I'd like to enter this into the record as well, as unanimous consent to do that. Sure. But you're doing a lot to be able to push Americans to think about health care in different ways and to be able to encourage us to do some of those things as well. And so I thank you for the research that you continue to do, and we'll look forward to continuing this conversation in the days ahead. With that, this committee is adjourned.
Ford this year.
Well, it's better than that lawnmower you got her last year.
She got a lot of use out of that lawnmower.
Look, Jim, you're right, okay? That guy was a jerk. That guy was a jerk, and I'm really sorry about the money.
Money!
But you know what? I am not going to let him or you or anybody else ruin Christmas for this family.
Chair, I'm sorry, that's already happened. It's already done.